world.
Oh, no.
Oh, no.
It's okay. They'll come and go.
Okay, perfect.
Yeah.
So right now, in 2020, we went up to 25.5% of maternal deaths in 100,000 over COVID. And that is pretty high for considering the world's death rate. So this is a lot of information for you about pregnancy. The biggest thing you need to remember about pregnancy is there's a lot of blood volume in a mom when she's pregnant. And another big risk factor she has is for blood clots. So like chest pain, all of that stuff, we really worry more about, like if they're having a PE or something. So those are the things we're looking for. And not that you guys are going to be measuring a uterus for a fundus, but if you ever want to know the measurement, like when we use the tape measure and measure how big a mom's belly is, that correlates with how many weeks she is. So if you have no idea and you want to happen to measure it, as in like this picture here, however high her uterus, the top of her uterus is, that's usually about how many weeks she's carrying. This is more for EMS stuff that I'm not familiar with. I'm just assuming it's a level of how urgent it is you need to get a mom to an emergency room. So the end is obviously very tachypnic. We have a low oxygen saturation, elevated temperature, any high range blood pressures. She just needs to go to the emergency room, and labor and delivery specifically, unless it's like a heart, like she thinks she's having a heart attack or something, we always want to see her first. But if it's more of like drug overdose or something like that, then she should stop at the ER first, because we do, and we can go to her at that point. Yeah.
So it's gone back and forth in the past, especially with IFC, of how we want to get to the labor delivery. Sometimes we say, get to the ER, you won't even stop there, someone will guide you there, don't park at labor delivery. Sometimes.
Oh. I would just, when you call the ER, just ask them what they want you to do, because I'm sure every hospital is different. At St. Mark's, we want you to come straight to labor and delivery. Don't even stop at the ER. Just come straight to us.
Do we park in a different place?
There's a roundabout at St. Mark's Hospital that just is right in front of the women's pavilion. The ER is on the far east side of the hospital. We're on the far west side of the hospital. Just pull up into that roundabout. Those doors are always open. Just come straight to us on labor and delivery.
Yeah, because one of the issues and people like do what they remember, right? So sometimes you don't even realize and you're like, oh my gosh, I'm at the back of the ER because I go here all the time.
Yeah.
But yeah, just
And it's a long walk.
Yeah, just
from the ER
go
to us.
straight to that roundabout. You'll be able to park your rigs in there.
Yep.
Should be fine.
Yep.
There are signs all over the place.
Yep. Yep.
Yeah,
There's
you literally
good-
just walk straight in and to the very end, you
Yep.
make a right.
to the right, and we're right there. We're on the first floor.
You'll look different next time you're up there, right?
Yeah, you're still going to be calling the ER, and the ER is going to notify them that you're
Yep.
coming in, so they'll be waiting for you at the doors.
Yeah, always call the ER first, because they're the ones that let us know you're coming. And honestly, even for any of, they'll probably say, just go straight to labor and delivery. You don't need to argue with them. Just bring her to us.
Well, because we as
We'll
ER
figure it
nurses, we don't like pregnant ladies
They
and we
do
don't
not.
like babies. So just.
All right, hypertension in pregnancy. This is one of probably the largest risk factors in pregnant women. And I feel personally that in the last year, we've had so many moms with high blood pressure. This is kind of going into the weeds of it all that you guys probably won't need to get into as much. But we have two kind of separate ones. One is like chronic or gestational hypertension. That's just related to a mom's blood pressure. And then we have the preeclampsia, eclampsia, and HELP. This is relating to like the disease process that happens to a mom when she is pregnant. Chronic hypertension is high blood pressures before 20 weeks, meaning she had blood pressure before she was pregnant, high blood pressures before she was pregnant, and we're just continuing to treat them. Gestational hypertension is she starts to get high blood pressure, but she doesn't have any of the severe symptoms that go along with preeclampsia. So there is no protein in her urine, no headache, none of those other symptoms. Preeclampsia, eclampsia, and HELP are the ones that we get the most worried about. So these are moms who develop high blood pressure in pregnancy, and then it goes into this disease process where it can make their nervous system very reactive, and it can give them a seizure. It can also give them blood pressure so high they could have a stroke. So how we treat these moms are treating their blood pressures, and just watching them really close and delivering them. So if you have a mom that has severe high blood pressures or has seizure activity, all of those things we're worried about help. So just like, do you guys carry labetalol on your rigs? Okay. That is like the number one blood pressure medication we give to moms, which you guys wouldn't have, but you could still treat a seizure with like an Ativan. Do you guys do Ativan or for seizures? Okay. Okay. Either of those would be fine for a mom and a baby to have, but just you really need to go to labor and delivery as fast as you can because the treatment is delivery. So all of those other medications we give mom is just to kind of help the symptoms so we can get her delivered. So for you guys in the field, just if you have a mom have a seizure, we need a blood pressure on her. If you can get a health history and to delivery as soon as we can. A baby will always look bad on a monitor. Not that you guys will monitor after a seizure. So we're just probably going to end up delivering her pretty quickly.
Do you find that after you've delivered these eclamptic moms, their babies, are they neurologically depressed also?
Well,
They-
if we have magnesium on them, on the mom, then they will be just because it does go to baby, but not related to the disease process.
Okay.
It's all just related to mom. But the process starts with the pregnancy. So if you remove the pregnancy and the placenta, then mom gets better very quickly. So, all right. Any questions about blood pressures, preeclampsia? A lot of the other symptoms we look for in preeclampsia, headache, blurry vision, like kind of flashing lights in their vision, a lot of weight gain, a lot of swelling, and then right upper quadrant pain because their liver enzymes get very high. So they'll have that pain in their right upper quadrant. And usually they just quote that they have a feeling of not feeling well. Most women who come in with this is they're just like, I just don't feel great. And then they have crazy high blood pressures and a really bad headache. So all of those things need to come to us straight away. 160 over 110, that is our threshold for a severe range blood pressure on a pregnant mom. So preeclampsia is the leading cause of maternal death. It's multiple system and it can progress really quickly, or it can be something we're watching throughout the last couple of weeks of her pregnancy. I had a mom come in and we evaluated her. Her pressures were kind of high. Her labs were okay. We sent her home, but said, if you still feel bad, you should come back. She came back in like 12 hours. And I was like, oh my gosh, we just saw this lady. The doctor was like, work her up again. She was in help in 12 hours. Platelets were very low. Blood pressures were crazy high. We ended up like crash C-sectioning her in like 12 hours. So it can progress really rapidly.
I have a question
Yeah.
for postpartum. So I had postpartum preeclampsia, and I had like my blood pressures were in the 200s. It was wild. However, so I know that the treatment for those is delivery, but what if they're advanced in that stages and they've already had the baby? Is it just magnesium
More
and
magnesium.
antihypertensive?
Yeah, so
Okay.
not often, but sometimes a mom will come in and we will deliver her because she has symptoms of preeclampsia. She delivers, her pressures are okay, she goes home, but in the next couple of weeks, her pressures continue to be very elevated and she could still continue to have headaches. Sometimes we do readmit them on labor and delivery for more magnesium. So again, if you have a mom that's delivered, high blood pressures, headache, not feeling well, she needs to start in the ER and then they will bring her to us because we will manage her even though she's not pregnant anymore, but she needs to be evaluated first in the ER. So start there. Magnesium, you say you don't have magnesium with you guys, and that's just something we would start as soon as she got to our unit. We give pretty high doses of it for this. We give like a 4 to 6 gram bolus over 30 minutes. So it's a pretty high dose. Yeah.
Does magnesium sulfate have any downside? Does magnesium sulfate have any downsides for that you guys are watching out for when you guys are pushing it?
Yeah, so it does, it's a smooth muscle relaxer. So it can decrease respiration rate. It makes the mom real tired. We usually put a catheter in because they're not great at what they're feeling very tired and they can't walk very well. And because it's a smooth muscle relaxer, it will also relax the uterus. So trying to get a patient in labor with magnesium is difficult, and a mom after she has a baby is a very high risk for hemorrhage after magnesium because her uterus is really relaxed. So those are all things we have to watch for moms on magnesium. They excrete it through the kidneys and through their urine, so we have to really watch their kidney and urine output really well to make sure that they're processing that magnesium and getting it out of their system. But again, all things you guys wouldn't really deal with. Okay. So preeclampsia are symptoms that are showing us that the mom is getting sick and could lead to eclampsia. So if a pregnant mom has a seizure, then she is in eclampsia. That's usually seizure, loss of consciousness, very agitated, and like I said, just a feeling of not feeling well. And because her pressures are so high, she could have a stroke. And then just magnesium and delivery are what we shoot for on labor and delivery. So just get her to us as fast as you can. Big IV. If you could start 2 IVs even, that would be better because she's a huge risk for a hemorrhage. So it's nice to have 2 IVs for us. So those are the things we would really appreciate from you guys. So maternal drug use. I feel like because, and maybe I'm wrong, I feel like the patients we get from you guys are very high risk because they usually are homeless or they don't have great help. They don't have great opportunities to achieve health care for whatever reason. So you sometimes get a little bit of a train wreck of a patient. Maternal drug use is a huge thing. It can put a mom into a hypertension crisis, a huge risk for preterm labor, and a placental abruption. So a placental abruption is when we have the placenta is attached to the uterus, and that's what gives baby nutrition and all of that baby needs. When a mom is a drug user, and it's more prevalent with like some drugs than others, they can make their pressure really high, and that placenta can just completely blow off their uterus, and that's like minutes for a baby. So vaginal bleeding related to a placental abruption is like we need to have a baby in like 10 minutes, and then it's huge risk for mom to hemorrhage after and to keep bleeding. So drug use is a huge risk for us. And then because of mom's high blood pressure and stuff, it can also obviously affect the baby. If you are at a delivery and the mom is a narcotic user, so fentanyl or any narcotic, all of that's going to go straight to baby. So you can also have a baby that's very, very respiratory suppressed at delivery. So you're going to be thinking Narcan. A baby codes 90% of the time because of respiratory arrest. So you want to make sure if you have a mom that you know is using narcotics, just make sure you have like bag mask ready for baby, because more likely than not, then you'll need to do some respiratory support for that baby. They'll probably be preterm, and they'll probably already be depressed from mom's use. And right at delivery, you won't see any of those like withdrawals or anything. It will just be like a really suppressed baby. Any questions about drug use on moms?
If we believe we have a placenta abruption, obviously, we're doing lights and sirens.
Yeah.
Which we can do for treatment outside of physician, warm, hypo-2.
No, IVs. Yep, 2 IVs if you can.
If she's, can they give TXA if they worry about that, or
They could if you have it.
they do?
Yeah. We usually don't give it until after delivery
Oh.
because it has, if I remember right, something with the PFO of baby. But I think if you're giving it and we're immediately delivering, but you wouldn't want to give like Methergin or not, if we're still have a baby not delivered, then you don't really want to give any hemorrhage meds yet until that baby's delivered. If baby's delivered, then by all means, all the things. Okay. So I feel like you guys also see a lot of MVAs that you bring to us, motor vehicle accidents. Big thing we look for on any maternal trauma, whether it's a MVA, whether it's an assault or a fall, or my dog jumped on my abdomen, or anything that happens like that. What we really worry about is, again, placental abruption. Any trauma that happens to a mom's tummy, we worry about the placenta just peeling away or just like exploding off. So that's vaginal bleeding, cramping, a lot of pain. So those are the things we're watching for. And again, just bring her to us, we'll monitor you. But those are the questions we ask her. Any bleeding? A lot of contractions? Are you feeling fetal movement? And I don't know how you guys determine who should come and who's safe to leave. I guess you just recommend everybody come if they're like in a motor vehicle accident. We do like if they're over like 28 weeks, we do like to do an extended amount of monitoring on them just because of the potential for trauma.
Statistically speaking, pregnant women are at the highest risk for assault and domestic violence when they're pregnant. It's just a sad fact of, so just kind of, keep your eye out for what they say their story is and what you're actually seeing.
We do a social screening on all of our patients. And one of the questions we have to specifically ask is, have you been abused in your home? And if they say no, we say, have you been hit or have you been slapped? Because sometimes women who are beaten, they don't even consider like a slap abuse. So we have to like specifically ask these questions because it's just really sad, but it is a higher risk in pregnancy. Postpartum hemorrhage. So your baby comes out, baby's looking beautiful. If your placenta is still not delivered, just leave it. Give that baby a minute and then cut your clamp your cord and just leave the placenta, let it do its thing. It can stay in for a whole like 30 minutes. We don't like more than 30 minutes or even an hour before we get nervous and have to like do surgery to remove a placenta. So if you can just get her to us, that's the most efficient way. But say you have like a drug mom or something and literally the baby comes out and the placenta just like comes out after, you're going to want to watch for blood loss. Greater than 1,000 milliliters is a hemorrhage, is what we consider a hemorrhage. So the uterus is ridiculously amazing. It can go from this big, holding a baby, to the size of your fist in like 2 hours. So what we're doing when we're rubbing a tummy is making sure that uterus is going from, where it was when she was pregnant, and it needs to come down below her belly button. So we just rub her tummy. You can, if they're real thin, it's real easy. You just kind of use your hand, you start at the umbilicus and kind of move down. And you want to make sure that uterus is getting nice and firm. Medications we use for that, Pitocin. Do you guys have Pitocin? Don't have Pitocin. You have TXA? TXA is good if you have it. Probably don't have Methogen or Hemabate. So the best thing, honestly, if you have a mom that's bleeding a lot, honestly, the best thing you can do, just keep your hand there and just don't move. Hand there.
CPR for that.
Yep. Hand there, you just keep rubbing that uterus and she's going to like pull your hands away and say, stop that. I don't like that. And you say, yeah, I'm sorry. I have to do this.
Because the fun on the side is supposed to be excruciating.
It definitely can be. So another thing that helps is a baby that's breastfeeding. So if baby's doing good and mom's doing fair and okay and can breastfeed, if you can get that baby to latch and breastfeed, and then you just keep your hand on that uterus and just keep rubbing it until she gets to us, that will help a lot. But if her placenta is still intact, you don't need to do any of that. The placenta itself is kind of acting as like a stopper. High risks for hemorrhage, like I said already, drug use, a big baby, twins, a long labor. So say you're taking a mom who was at a birth center that's been laboring for 4 days, water's been broken for 3 days. She's probably got an infection. That's going to make her uterus not want to clamp down and get real hard. And it's just a really long labor makes her uterus real tired. So sometimes you bring those to us too. Postpartum hemorrhage can occur up to 6 weeks postpartum. Usually that's because pieces of the placenta are still inside the uterus and they haven't come out. And that doesn't happen a ton, but it does happen. So if you have a mom calling you and she's bleeding a lot, just bring 2 big IVs are great, and then just bring her to the emergency room, because again, they'll start her in the emergency room because she's not pregnant. And then our OBs will usually come and help assess if that needs to come out. Yeah.
For at least Murray Fire and then you guys, we do have an order of Pitocin, and we're going to start carrying it coming up in the future. Greenwell maybe knows a little bit more about, and the TIA, but that
Awesome.
might help as far as treatments and discussion as you're talking today.
Yeah. 10 units of Pitocin IM. Like you don't even have to have an IV for that. Just give it IM. TXA, you do have to have an IV for. But yeah, so far. Hypovolemia. Hypovolemia, again, just a mom. It can be a mom that's just delivered and had a huge blood loss. It can be a mom that's been delivered for 6 weeks and just every day has had a little too much bleeding, and now it's 6 weeks and now her crit is nothing and she's just feeling real crummy. So that's going to probably end up in the OR to help do a DNC and remove whatever is causing her to keep bleeding. So IVs, O2 support, fluid, resuscitation, and just straight to the ER for her. We at St. Mark's, I don't know how other facilities are. They can bring their babies with them. We will not see a baby if they don't want us to. So say a mom has a home birth because she planned a home birth and then something happened, she bled or the placenta didn't come out, unless you're bringing them to us because of the baby. If you're just bringing them because of mom, we do not have to look at that baby. We usually won't. So if the mom's really worried, like, I don't want you to take my baby to nursery, we won't. That baby's not even our patient. So we would just care for the mom. Baby's very welcome to be there. We're very happy to support her with diapers, helping her breastfeed, helping her care for her baby while she's not feeling well, and then they can all go home together. So if anybody's ever worried about that, just bring your baby with you and we won't treat the baby or take it away for any reason. Okay. Any questions about postpartum hemorrhage?
You're so
Okay.
quiet.
I know. We kind of already talked about this. The number one cause of bleeding is usually just what we call a boggy uterus, a uterus that won't clamp down. And those reasons, like we already reviewed, infection, big baby, long labor, drug use. Tissue retained products would be placenta that hasn't been removed. Trauma, a lot of our trauma, blunt abdominal impact, but to me, when I think of trauma, I think of a traumatic birth. So we could have a cervix that got tore because she went really fast and had no control and was at home alone and screamed and had a baby. So that cervix can tear. And if the cervix tears, it bleeds like crazy and it won't stop until we put a stitch in it. So she just needs, and no medicines will help that. That's like a active bleeding wound that we have to close to get that to stop. Or like a perineal laceration. Again, a mom at home that has a baby coming real fast, that could be real big, that she doesn't have a lot of control over, and that can just really cause a lot of trauma. So that, again, no medications will help that. We just need to get in there and close the open sutures or the open wound and get her to stop bleeding. Clotting disorder. Moms are at risk for blood clots in pregnancy. Some moms take like a baby aspirin for that if they've had a lot of miscarriages. It's not uncommon for a provider to diagnose like a baby aspirin, so that might be something you want to ask. Or they might even be on Lovenox because they have a history of a PE during pregnancy. Vital signs every 5 minutes, fundal massage, just keep that hand on that fundus and just keep rubbing it, large bore IV and O2, warm blankets. I'm not gonna lie, warm blankets even at the hospital is something we forget because we just get, and patients like, I'm freezing. We're like, oh, sorry, have some blankets. Oh, save all blood product, save all towels, anything she had at home, anything you have with you. That's the best way for us to estimate how much she has bled. And we will weigh it all and then try to do like a dry weight on what we can. So if you guys have like chucks or specific you carry with you and you could tell us what the dry weight is, or even bring us a dry one, and then the one that's saturated, then we can know exactly how much blood loss she has. That's how we estimate blood loss on labor and delivery, is just by weighing everything. So her clothes, towels, anything, it kind of gives us about a ballpark of how much she's lost.
Don't bring the pool water.
No, I don't want that. I don't want a mucus plug either. Don't bring me that. Fundal massage, CPR for maternal hemorrhage. Again, just if the placenta is already out, the placenta's in, just let it be in. Even when I do a delivery at the hospital, if the provider's not there, I just leave the placenta until he gets there or she gets there to finish the delivery. So the biggest thing for a cardiac arrest in a pregnant patient is that you just want to move that baby off that big vessel down her back. So if you're doing CPR, somebody's doing CPR, somebody needs to be holding her tummy and pulling it to the left just to kind of relieve that pressure. So all of that resuscitation is going well. Again, if we have a mom that's coding, like we're delivering her. I've done 2 deliveries in labor room, not in the OR because we had a mom crash. So we're just delivering as soon as we can. Big IVs, 2 of them. Get her to us as fast as you can. Yeah.
Is there a contraindication for the Lucas on the pregnant women?
For what?
Oh, the Lucas is a device that they put on that does compressions for them.
Oh,
Um,
I feel like
So-
if a mom is, I don't think it would hurt.
yeah, just make sure you move the baby.
Yeah, just have somebody kind of pulling that baby to the left so that it's off her, vessel there. And then this is just, do you guys do ACLS or BLS? Advanced, yeah. So this is just the advanced, and meds are all the same. Everything's the same. Just kind of pull it to the left.
Guys are familiar, this document, something similar?
It's just right in ACLS.
Yeah, I feel like if you do ACLS, this is pretty much the same guideline. Precipitous deliveries, probably a lot of what you guys help us with. There's no need to ever like check a cervix or anything like that. If a baby's coming out, it's coming out. Like you don't need to be like, maybe we're almost there, like we do on labor and delivery. Usually what I do when I have a patient going really fast, you just kind of check every now and again, see if you can see that head starting to crown. Recent drug use is a big reason for imminent delivery. A mom that's had 5 babies, she can go, once her water breaks, they can have a baby so fast. Once their water breaks, they'll go really fast. If they had a bunch of babies, vaginal bleeding, again, a mom's always going to bleed when she's in labor, just called bloody show. So that's all very normal. So you don't need to be worried about that unless you feel like it's a hemorrhage, and then she could be delivering quickly because she has a placental abruption. When the placenta comes off the uterus, the body knows like this is not good, and it will just contract and contract and contract until that baby comes out. So they have a lot of pain, a lot of contractions, and usually a very, very fast delivery.
And to clarify, that pain would be more of a sharp tearing pain. rather
Yeah.
than pressure.
Yeah, and it usually doesn't stop. It's not usually like, oh, it comes and then I can relax and talk to you. It's just like so intense and it never stops.
Oh, now.
Uh-oh. So
Good.
exciting. Oh, yeah,
Yeah,
anytime.
He'll know how to handle all this.
Yeah. And then a mom feeling the urge to push. Even on labor and if a mom wants to push, you can ask her to try to blow out candles. That's one thing we say to moms when we want them to wait a minute. And that's just like a deep breath and breath and just blow out a candle as long as you can. If a mom's unmedicated and needs to push and have a baby, there's nothing you can do to make her stop. And she's going to have a baby. So supplies. What kind of supplies do you guys have on the ambulance for delivery?
We have prepackaged OB kits.
Uh-huh.
And the other thing, it's got like 2 gowns, a few shots pads to try to make your. Yeah, yeah.
Perfect. 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 So that's all you really need to have a baby. The biggest thing we have when people deliver at home or in an ambulance and come to us, those babies are always cold. So you just have to be so, so careful. A baby delivers, you dry that baby off as best you can. You throw that wet blanket away. You grab another clean, dry blanket. If mom is warm, put that baby right on mom. Oops, sorry. And then a blanket over the top and a hat, especially if that baby has a ton of hair. Dry that hair as much as you can and a hat, and just bundle them up as best you can. If a baby's cold, it's going to drop its blood sugar. It's going to affect its respiratory rate. It's going to end up in the NICU. So a warm baby is like really big for us. Maternal history. So I honestly feel like a lot of the moms you bring us, they're like, I didn't know I was pregnant, or like, it's just, who knows what they're going to say. So the best history you can obtain from them is always very helpful. who their doctor is, it doesn't really even matter where they're going. We just like to reach out to that physician to try to get records from them. So that's the only reason we want to know who their doctor is. And then, yeah, just keep the patient stable. There's not a lot, honestly, if a mom's imminent to delivering, even on labor and delivery, I don't do it. You want her to deliver as slowly and in control as possible. That's really like the only feedback to give a mom, just like slow panting. There's going to get a point where she just can't. But if you can let that head crown slowly and deliver slowly, and then just a little bit of down pressure if you need to. I feel like if a mom's delivering for you guys, it's usually happening so fast, there's not a ton you can do. So usually you give just like a titch of down pressure so that shoulder can kind of sneak under that pubic bone right there. And then usually they kind of like figure out, they kind of turn around a bit and figure out how they want to go. And they'll usually go down and then you just deliver them. If a baby comes out sunny side up, it's totally fine. It's just a more painful hard delivery for mom, fortunately. If you see a nuchal cord around the baby's neck, if it's loose, you don't even need to do anything. That baby will still deliver just fine. If it's around the neck real tight and you can tell this baby cannot come out because it's stuck with this nuchal cord, that's when you would want to clamp above, below, and cut, and then deliver the baby.
If it's loose enough, would it be?
Yeah.
Slip it over?
No, not at all. If you have time and you want to do that, that's totally fine too. I've had 2 deliveries unattended by providers, both the nuchal cords, and they literally just like, bloop. I was like, oh, okay, we're done. So if you feel like you have time and you want to do that, it's totally fine. It's definitely not something you have to do. They'll figure it out, usually, unless it's so tight that they can't actually make it out. Let's see. Gestational age. So early babies, there are some ways we can tell that a baby's early just by looking at it. If a baby has what we call is real cheesy, it has a lot of vernix on it, that means the baby's early. It's real hard to wipe off and it's very like distinguishable. You're like, oh, that's an early baby. It's got a lot of vernix on it. If they're overdue, their skin is usually really dry and peely. So that's usually an indication that they're overdue. Another, if they're really early, obviously size, and then they'll have a lot of that really fine hair on them all over. Not like cute furry babies that just have a lot of hair that's sometimes on their shoulders, but like all over their bodies. They'll have a lot of that hair. Sorry, I just want to make sure I didn't miss anything else about early babies. Early babies, you really want to make sure that they stay nice and warm. And you honestly don't want to like vigorously like stimulate them very much if they're real early, like under 32 weeks. If you have like a normal term, looking term, it's pink, it's crying, you're welcome to go ahead and stimulate that baby as much as you want. Let's see. How many births they've had, have they had any C-sections, all things we really want to know. If there's a problem with their placenta. So sometimes when the placenta implants, it can implant over the cervix. That we cannot have a vaginal delivery with the placenta over the cervix. They'll just bleed and then the baby can't get out and that's a huge hemorrhage risk. So those are straight C-sections. If they have a low-lying placenta, sometimes that's sitting real close to the cervix and they can bleed a lot when they go into labor. So if you are having a lot of bleeding, you can ask, are there any concerns about your placenta? Do we know, is it a placenta previa? Is it low-lying? If they have a placenta previa and they've seen a physician, they will know. It's a very high-risk pregnancy, so they should know that. Let's see. Drug use again, if they're honest with you. And we on labor and delivery really try hard to like tell the mom, like, we're just asking these questions because we want to take care of you and we want to take care of your baby. And if we don't know the medications you're taking that are illegal or not, then we don't know how to take care of you and your baby. So sometimes they're a little more forthcoming when we phrase it like that. Not always. And then we recommend a patient go to the ER if they're saturating a pad in less than an hour, but bleeding more than an hour, one pad in more than an hour is like a very normal amount of bleeding for a mom in labor or after delivery. So this is kind of what I was showing you. So usually when we're crowning, so this is crowning right here. And that baby kind of comes under that pubic bone. And then we kind of go down a little bit, push that baby down, under, and then delivery. If you have a mom pushing real hard and going real fast, you don't have to help with any of that. They just figure it out. So, shoulder dystocia. So the most common way to get a baby delivered with a shoulder dystocia, well, first, risks of a baby having a shoulder dystocia. Really big baby. A mom that has diabetes that's not well controlled. If she's had a shoulder dystocia in the past. All of those things can tell us that this baby's going to be big. If she's measuring big, if she tells you this is a really big baby, then we're at a risk for shoulder dystocia. As the head comes out, sometimes they'll crown a really long time, the head will come out, and then they kind of do this turtle where they sink back in. Usually a baby head should come out, and then they kind of do that like downward motion and just continue delivery. When you have the shoulder dystocia, the head comes out, that shoulder gets stuck, and they kind of get pulled back in a little bit. The number one way that to deliver a baby with a shoulder dystocia is to start some maneuvers to help with that shoulder, get underneath. And the first one we do is called McRoberts. So McRoberts is when we just bring her legs very far back, open her pelvis as wide as we can. Doesn't it? It's kind of sketchy. So when we bring her legs back and open her hips really wide, it opens this pelvis more. So then this baby's shoulder can come down and end up finishing delivery. Another thing we do on labor and delivery, and I don't know if you guys would ever have to do this, we do what's called suprapubic pressure, never fundal pressure, never from the top. You never push a baby this way out of a mom that's stuck. We do suprapubic pressure. The way the baby's facing is usually the shoulder that's stuck. Take your fist, push down, and you try to push it under that while somebody's helping deliver baby. So that's honestly usually the best way to get a baby with a shoulder dystocia. If you do those two moves, McRoberts, legs really far back, push them like to her ears, real far back on her legs. And then if that's still not happening, a push right here. Another thing is usually at this point, the mom has had a hard labor, the head's out. Sometimes they get very like, I'm done. No, you're not done. We got. So you got to really make her focus, really kind of not like scare her, but like this is an urgent situation. You have got to get it together and you've got to push again. Because a mom that won't push, this baby's not going to come out. So you got to get the mom looking at you, in control, push hard with each contraction. In between contractions, slow, deep breaths. Calm down. Let's do a push. Make every push count. Real hard pushes. And then if you need to, that pressure. Sometimes the physicians will go in and try to deliver this shoulder or even this posterior shoulder. And they literally just grab the arm, pull it out, and then finish the delivery. I've never done that.
So mainly, is there anything that the catcher is doing in this?
No. Honestly, if you're being the catcher, your job is to get that mom to focus on you, calm down, and when she has a strong contraction, she's got to push as hard as she can in control. The screaming and yelling and loudness doesn't help, which is really hard to say, but what we say on labor and delivery is like, you need to stop all of this out, keep it all inside, and just push as hard as you can, because that's what's really going to help her have a baby. All the screaming and stuff is taking all that power and pressure away from pushing a baby out. We want to know the head, the time the head delivered, and the time the baby delivered. NICUs are really going to want to know that. How long was this dystocia? Was it 30 seconds? That felt like an hour? Or was it literally 10 minutes, a very, very long 10 minutes? Lower head of the bed is also really important. So if you have a patient on a gurney or something, if she's like pushing, like sitting up like this, she needs to lay way, way flat, all the way flat. Legs, McRoberts, really wide, way back, suprapubic pressure. And then all of these are really kind of advanced, either delivering a posterior shoulder, delivering an anterior shoulder, breaking a clavicle, turning a baby all the way around, or Zavanelli's is pushing the baby back into the uterus and doing an emergency C-section. I've never done that. I don't ever want to do that. So usually those first 3 maneuvers will get you there or get you to us and calming the mom down and really having her push. That's honestly, even on labor and delivery, those first 3 are the ones we use the most. Any questions about shoulders, Tosha? Yeah.
Well, I guess it's not shoulder stuff. You do was it the Zavanelli where you push it in? Is that what you do when the cord presents on top of the head?
Kind of, yeah. So cord prolapse. So say a mom calls, my water broke, there's something weird hanging between my legs. So what happens when a cord prolapse happens is usually the mom has a ton of fluid and the water breaks and the baby's head is like floating in her pelvis area here. So then if we have a cord anywhere here, when the water breaks, it sneaks down and then the baby's head puts pressure on the cord and that completely will cut off a baby's like oxygen supply. So what you want to do is when we're doing it, it's just like a cervical check, sterile glove or gloves. I don't know if you guys have sterile gloves on them. A glove is fine. Up through the cervix. If her cervix is usually going to be open because the cord came out. Just follow that cord. Try not to touch. The more you touch it, the more a baby's going to vagal and have that like drop in heart rate. So as much as you cannot touch it, you want to just kind of trace it where it's going. Put your hand on the baby's head. Usually you can only get like 2 or 3 fingers on the baby's head and you're going to push it out of her pelvis. So that cord that's dropping here has room to keep pulsing. So you're going to be like through the vagina, up into the cervix, through the cervix, touching the baby's head, keeping the pressure off of the baby's head. And you stay there until we're in the OR and having a baby.
See the cord pulsing?
You can usually feel it.
That's supposed to.
Yeah, you don't really want to touch it, but usually it does kind of just rise against your fingers and you can kind of feel it pulsing. And that's really helpful too. You can be like, it feels about 100 or 60. We need to go faster.
We just had one at Lone Peak with Draper Fire. They had twins that were being delivered, had a prolapse cord.
Scary.
And they transported mom in the knee elbow position
Oh yeah.
and had pushing the pressure off the cord, and they transported. Once you commit to that, you're done.
You do not move.
You're there. You don't
You're
move.
it. You
They
come to the
came
OR
all the
with
way
it.
through the transport, in through the ER, out to labor and delivery, where they went in for a C-section, and they couldn't release their hand until a nurse went in and replaced it.
Yeah.
So, and they had a great delivery on that one.
Yeah.
Both twins came out they were preemies, and they spent about a month in the hospital and came out just fine.
Amazing.
So,
So hands and knees will also help, just like the gravity of it, kind of keeping baby's head going this way instead of this way. So you don't want her like sitting up. You kind of want her like hands and knees with her bottom in the air to kind of help with that. And usually there's no risk for mom of that. It's just all baby. A cord prolapse is we're all worried about baby. Kind of went through that. Breech deliveries. I've done a handful of twin breech deliveries. If we have twins that are head down and then breech, we will do that delivery in the OR with like everybody ready to crash in case we have to. I did actually just do a vaginal full term breech delivery, which is the first one I've done in 17 years, and it was very scary. So I'm not the best person to educate you about breech deliveries. I would never say like, again, the mom's like, there is something between my legs and it's like a foot. I would just not touch it, get her to the hospital as fast as you can. I would not attempt a vaginal delivery, like a breech vaginal delivery. If mom is able to like pant through it and get her to the hospital, that's the best outcome. Because the worst is when the legs, bum, tummy are the smallest, right? Shoulders next, and then the head's the biggest. So when we have a breech delivery, we usually have a cervix that's not completely dilated. So we get this part out, shoulders out, and then a head entrapment. And that's very stressful and very scary. We do have forceps we can use to go through the cervix, put on the baby's head, and pull it out vaginally. But say you have a mom that's, if it's preterm, that can happen kind of often because they're not usually head down yet when they're preterm. And she has a foot just hanging out in her vagina. Just get her to the hospital, IV in her, get her to the hospital. I would not attempt to deliver that baby. If she can pant through it and get to the hospital, that's what you want to do. Yeah. Oh, sorry. Hey. cord prolapse. So we just talked about, that's a good picture of it. And you would just want to put your hand here and push on baby's head this way so that it's taking the pressure off of that umbilical cord.
Baby's head is up in the uterus.
Mhm. Yeah, that baby's, I mean, a baby can deliver past a cord, but usually the mom notices very quickly, like, oh, something is very wrong. And so the baby usually doesn't deliver. Usually you get her to us before she delivers. Care of baby. Do you guys do NRP? House? Okay. So, like I said before, the number one reason a baby codes is respiratory. So whether it's because mom hemorrhaged or had like a lot of blood loss and there was no volume, or whether it's because mom is using drugs and been very suppressed. Oh yes, thank you. So with resuscitating a baby, so a baby comes out, you have a blanket, you wipe dry, wet blanket, throw that away, get another dry blanket. If this baby still isn't crying after 30 seconds of just kind of stimming and rubbing, it goes into what we call secondary apnea. No amount of stimulation on a baby will bring a baby out of secondary apnea. That baby needs breaths. So 30 seconds of this. If you ever get a chance, like after your baby's born or before they cut your baby's cord, you can check a pulse by just putting your hand right where that umbilical cord attaches and you'll feel that pulse. So we have a baby that's blue and not responsive. I dry, I take it, throw away the wet, I dry, I bulb suction mouth first, nose, and then I check a heart rate. If my heart rate's still good, then I continue to give breaths if the baby's not breathing, right? That's 1 every 6 seconds. We do breathe in 2 and 3 and breathe in 2 and 3 and breathe in 2 and 3 and breathe in. So you do that. We actually have T pieces now, which are really convenient, but I bet you guys probably have bag masks, right? So, and then if baby's still blue, still not crying, still not doing great, you're going to suction out again. Suction, make sure baby's dry, check a heart rate. If the heart rate goes below 60, that's when we start compressions. So number one, respiratory. That's usually what's wrong. And usually, honestly, just a couple of breaths will bump it out of that secondary apnea, and it's usually fine. Chest compressions, we like around, my hands are really small. It's actually really hard for me to do the new way, but that's the kind of way we like it. 1 and 2 and 3 and breathe in. 1 and 2, it's 2-person breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. And then just get them to us as fast as you can. I don't know how other hospitals do it. I've done it 2 ways. I feel like it's best if that baby's going to go to the NICU. Because at St. Mark's, we don't have a pediatrics unit. So that baby's always going to go to the NICU. So call the ER. I'm coming with a baby that's not responding after a delivery. If they say go to the ER, go to the ER. But if they say the baby's probably going to end up in NICU, should we start in women's? Because you could just bring the baby to us on labor and delivery. We can resuscitate it on labor and delivery because our NICU is literally right next to us. So NICU, we would have everything already waiting for you. Bring us a baby, we'd start. So if they say to go to the ER, we got to take all our shit to the ER. And then we got to run it all the way back to the ICU. So we would like it to come to NICU the best. Meds wise, I think you'd get to us before you would try any meds. I would just suction and try to get an airway and try to get breaths going. That's like the biggest thing you want on a baby. And keep it warm. Warm. Hot, warm.
Reagan, do you have, so if the mom has gestational diabetes, are you going to see a drop in the baby's sugar like right off the bat? Could that be a reason for depression or?
No, usually we see a drop in babies' blood sugars in like 30 minutes. Usually they're fine. Usually it's a narcotic, like a drug use, like a med mom problem, or it could be a blood loss. The hard thing is if we have like a placental abruption and we deliver a baby and a baby's not doing well, it probably has no volume because the volume all bled out while mom was bleeding. So if you have like a pale baby with no color, like that's kind of the worst outcome situation. A pale baby's worse than a blue baby. What else can I tell you? Not that you guys can do much about that. Just get her to us real fast. Kind of I was talking to you before, you have a baby that delivers, mom's like, I'm not a bit like not able to give you guys any information. She doesn't speak English. Whatever reason, she can't give you any information. A baby comes out, the first thing you want to know is it term? So those things you're going to look for. How big is this baby? That's about term. This is kind of big, but that's about a term size baby. They're going to have maybe a little bit of that vernix on them, but not a whole ton. You can just wipe that off. And then their skin, when they're early, kind of has like a really fragile, like their eyelids are really thin, kind of like a really fragile look to them. So if you can tell kind of like, okay, this baby looks preterm, it looks term, just so you can, when you call, you can let EMS or let the ER know. Tone, is this baby just like so floppy and like not responding to me at all? Or is it having that startle reflex? And all of those are good things. All of those are good. I'm term, I'm happy, I'm crying, I have good tone. And then breathing and crying. If a mom takes antidepressants, sometimes that baby won't cry. And it will be pink and it will have good tone and you have a good heart rate, but it won't cry because antidepressants do go to baby and they do make them just real chill. So as long as it's pink and it's crying, I'm not crying, breathing, and it has a heart rate, that's fine. We usually just ask mom, are you on any kind of antidepressant? And 9 times out of 10 nowadays, they kind of are. So
One-
it's not uncommon to
One
have a baby
big
that.
thing I've had happen to me in the ER was that they delivered the baby, or the baby was actually a fetal demise,
Mm,
delivered, obviously was not alive, but during the resuscitation, they were rubbing the baby, like, doing all the things. When a baby is a fetal demise, depending on how long they've been in there, their skin is unbelievably fragile.
yeah, it's
And so
slough
you can
really
actually
easy.
rub the skin off. So like,
Even
it's,
even on a baby that's not past that, you can get nervous and excited and just get a little too rough when you're given that like breathe, 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 cry, cry, cry. Like even nurses can get that. 30 seconds of this, move on. This is not only 30 seconds of making that baby try to cry. Like rubbing her feet is good. Flicking their feet is good. If they're still not crying, you got to breathe. You got to do breaths. No amount of this is going to make a baby cry that's already in an apneic state. So this is kind of your like basic CPR stuff that I'm sure you guys know. We don't want to like do a huge tilt, just like what we call sniffing position. So just a little bit of a raise. If the baby's breathing, but it's breathing slow or gasping, go ahead and just start breaths. Again, it kind of usually will kick them out of it and they'll start to breathe better on their own. Do you guys have continuous pulse oxes for babies in the ambulance? A continuous pulse ox? Right hand. Right hand? I always forget. Yeah. Right hand on a baby. And then if you're resuscitating a baby, sometimes you won't get a oxygen rate because it's just so low. So just keep it on, keep working, and then usually it will eventually kind of start giving you some input. The Mr. SOPA is respiratory, the steps we go through for a respiratory resuscitation. So say we have a baby, we're trying to resuscitate, it's not working. We do Mr. SOPA. mask adjustment. Do I have the right size mask for this little baby's face? Is it over the nose and just to the chin and there's no air leaking? Reposition the neck. Am I this? Am I too far? Am I just that sniffing position just right? S, suction the mouth, nose. And then maybe increase your pressure. If you have a preterm baby, they need more pressure than a term baby because their lungs aren't quite ready to take to breathe yet. So it may be just that this baby's early and you need to give it just a little bit more to pop those lungs open. And then if those aren't working, alternative airway, intubate a baby. We usually resuscitate babies just with room air at start because even sometimes too much oxygen is bad for a new baby. So we usually start with just room air. And then if you have a continuous pulse ox and you're getting good airflow, but the oxygen is still low. And just also remember, a baby's oxygen doesn't get to 90% for like 5 minutes. So if you're like 88, 89, like that's great. You don't need to be 100% at like 5 minutes of delivery. It takes a minute for all of that to go. Less than 60 after. So a baby comes out, it's not breathing, the heart rate's less than 60. We still do respiratory first. Don't start compressions yet. Usually if you can get good respiratory resuscitation, the heart rate will follow. So 30 seconds of good respiratory effort. If you have good ventilation and everything's going good, that heart rate should rise. Give it 30 seconds. After 30 seconds, reassess the heart rate. If it then is below 60, that's when you start chest compressions. Again, epinephrine, I don't know if you guys are going to be 1 milliliter in an ET tube on a baby. That's a lot. So I don't know. You probably would just get to us before you tried to give any medications. Okay. So that's, I think I kind of talked the things labor nurses really wanted you guys to know. We love times on labor and delivery. What time was the head, if you know, and what time was body delivered. Those are big things for us. APGARs. Do you guys assign APGARs? Yeah. So color, tone, reflex, heart rate, and respiratory effort. So most like healthy mom, healthy baby, your 1 minute APGAR is going to be anywhere from like 7 to 9. They usually aren't pink in 1 minute all the way. And they sometimes are a little grunty, so a little respiratory effort. Usually by 5 minutes, you should have like a 9 or a 10. Baby's hands and feet are usually going to be blue for a while. So usually even at 5 minutes, we're at like a 9 because color's still off for 1. We had somebody bring us a patient that was preterm, 32 weeks, really uncomfortable, looked like she was going to have a baby. And they did give her fentanyl in the ambulance. I would just highly discourage that. That fentanyl is going straight to baby. And then we did end up delivering a baby. So we have a 32-week preterm delivery with fentanyl on board. Just makes the baby harder to resuscitate. So I wouldn't give a mom any narcotics in an ambulance. I would just say, I'm really sorry. We got to figure out what's going on first. We got to get you to the hospital. Because if she's delivering in less than an hour, we don't want any narcotics given to her.
Reagan, what are the preferred like key items that you want these guys to give in their report? Like if there's 5 points about a report, say we have a 59-second report thing that the charge nurse is writing on, like what are the biggest things that you guys want to know from labor and delivery?
If she has prenatal care, does she know her due date? And then what's her complaint? If she's already delivered, what time was delivery? How's her bleeding? And then just keep that baby really warm. I feel like you guys either bring us patients that there's nothing going on and we discharge them in an hour, or you bring us patients that are like having a baby. So that's kind of like this big thing. But yeah, those are kind of the biggest things we want to know. And if she's there for like, if she's complaining of headaches, blood pressure. We want to know blood pressure. And an IV is always amazing. You guys are usually always really good about that. And yeah, do you guys have any other questions for me?
What was the pubic pressure you were talking about?
Super pubic pressure. Oh.
Super pubic pressure.
So you have a baby that is stuck, shoulder dystocia, So the head's out, but our shoulder is stuck behind this pubic bone, either because it's a really big baby, you have a mom with just like a really narrow pelvis. Diabetic moms have really big babies if they're not well controlled, so that's a big risk factor. So with her legs back up, her head all the way down, one person, whichever the baby's facing, is usually the shoulder that's stuck. So you're going to put just a fist right above her pubic bone and just try to push that shoulder down while she's pushing. So you don't want to do it if she's not pushing. You're going to kind of do like all efforts at the same time. Okay, calm down, take a big breath. We're going to take a really big breath and we're going to push and it's going to count and we're going to push real hard. And while she's pushing, you do that. Not enough to like hurt her, but enough that you can feel that. Because I'm short, I'm usually like on a bed and like my whole weight. Yeah. So like one good compression.
One of the things too is making sure you're pushing down, like if this shoulder's up like this and you're actually pushing the wrong direction.
Yeah.
Is you can actually complicate things.
Yeah, you can make it more go this way than go this way. So usually whichever way the baby's facing is the way you want to go that way. Yeah, where the baby's facing. Because if I'm on this side and I'm pushing it this way, that's not going to help. So if the baby's looking that way, you're going that way.
So if the baby is, coming out, if you look at the top of the head and you see a diamond, there are those sutures, that's great. If you look and you see, triangle on the back, and then if you look and you see a diamond, that means this is anterior fontanelle and it's there.
Which is still fine, just a more painful and a longer pushing. And it's kind of, and sometimes the heads look real weird if they come out sunny side up, because you know how usually babies have that really big cone head? If a baby comes face up, sometimes that cone head is right here on their forehead and they deliver and you're like, what is that? It'll go away. It's fine. Yeah. Does somebody want to be a demonstrator? Just kidding. I don't know. That might be a little personal.
It might be easier to show on that one.
Well, we just need like legs.
We can probably stop the recording, go to
Yep.
hands-on,
Yeah.
go that way. So is there any questions online that anybody has? If so, unmute and tell us. And do you guys have any other questions before we?
Yeah.
Because now is the hands-on time. We get to bring up there and play. But
Baby's born with the sack
Oh,
over his head already.
we usually just break it. So like scissors.
I gotta do one. That was pretty cool.
It is really cool. Yeah.
yeah.
I mean, even if it's not sterile, because it's not going back in mom. Like if the baby comes out and the bag of water is still completely intact, like it's really cool to see a little baby just like floating in there and then just break it open.
It's really cool until the bag of waters breaks and then you get painted against the wall.
Kind of do it like this.
Okay,
Yeah.
I'm going to go ahead and work, all those online, thanks for being here. We'll go ahead and stop this part. We'll move into some hands-on here for locally. So appreciate you being here today and have a great day.
Yeah.